Welcome to the Deep Dive, the program where we cut through the noise and get straight to the crucial insights you need to be truly well informed. Today, we're plunging into a topic that's, well, absolutely fundamental to sports medicine: the immense repetitive stresses placed on the human body in elite athletics. We're specifically honing in on the elbow, a remarkably complex joint that's often overlooked yet incredibly vulnerable, particularly in throwing and striking athletes. It's susceptible to some very specific, often challenging forms of injury that can frankly derail a career. Our deep dive today will thoroughly unpack elbow injuries in athletic performance with a laser focus on a condition known as valgus extension overload syndrome, or VEOS. We'll explore its common presentations, delve into the intricacies of diagnosing and treating it, and then, crucially, examine a compelling case study that truly showcases the profound impact of a highly individualized, movement-focused approach to rehabilitation. To guide us through these clinical insights and the latest research, we're incredibly fortunate to have with us Professor Mo Imam, a distinguished expert in orthopedic conditions and sports medicine. Professor, it's a real privilege to have you join us for this discussion.
Thank you. It's a genuine pleasure to be here and delve into what is undoubtedly a critical and often challenging area of sports medicine. I think this deep dive will offer some valuable clinical perspectives for your listeners.
Okay, let's unpack this then. Before we delve into the injuries themselves, could you perhaps walk us through the fundamental anatomy of the elbow and, crucially, the unique biomechanical forces at play during those overhead athletic movements? It often feels like a bit of a paradox, a joint designed for power, yet so susceptible to break down under repeated extreme stress. Where does that story of injury truly begin, anatomically speaking?
That's a vital distinction, and you've really hit on the core paradox there. The elbow joint, or the cubital joint as we formally call it, is far more sophisticated than just a simple hinge. It's actually a compound synovial joint formed by the articulation of three bones. You've got the humerus, which is your upper arm bone, and then the two bones in your forearm, the radius and the ulna. Functionally, it's a sophisticated combination. You've got a hinge joint, that's the humerolar joint, allowing you to bend and straighten, flexion and extension. But it's also a pivot joint, the humeradial and proximal radiolar joints, which lets you rotate your forearm, pronation, and supination. This dual functionality, well, it allows for the incredible dexterity and power required in these athletic movements. Now, a key anatomical landmark, which becomes highly relevant in conditions like valgus extension overload syndrome, is the olecranon. This is that prominent bony point at the back, the upper end of the ulna. You can feel it easily under the skin. During full extension, the olecranon fits snugly into the olecranon fossa of the humerus, providing a sort of bony block that limits hyperextension. Its involvement in VEOS is direct, really, as it's the site of that repetitive impingement we see.
Right, that bony point at the back. And the ligaments, I imagine they're under immense pressure, too.
Absolutely critical, especially in throwing athletes. We have these thick collateral ligaments that stabilize the joint. On the intermedial aspect, we find the ulnar collateral ligament, the UCL. It's not just a single band. Typically, it comprises three distinct bundles: the anterior, posterior, and transverse. Now, the anterior bundle is overwhelmingly the most crucial in resisting valgus stress.
And valgus stress is that outward bending force.
Exactly. That outward bending force on the elbow, particularly between about 20 to 120 degrees of flexion. And that's precisely the arc of motion you see during the most forceful phases of throwing. On the outer lateral side, you have the radial collateral ligament complex, providing stability against varus forces, so inward bending. The integrity of these ligaments, especially that UCL, is just paramount for joint stability during dynamic movements.
So you've got the bones providing structure, the ligaments providing static stability. What about the muscles? Do they play a role in holding things together too?
Yes, significant dynamic stability comes from the muscles. The flexor pronator muscles of the forearm and wrist. They originate from the medial epicondyle of the humerus, that bony lump on the inside of your elbow. Muscles like pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis. When they contract powerfully during throwing, they help compress the joint and provide a sort of counterforce to those valgus stresses, effectively supporting the UCL. And importantly, we must also consider the ulnar nerve. It runs right behind that bony prominence on the inner elbow within a groove known as the cubital tunnel.
Ah, the funny bone nerve.
Precisely. It's responsible for motor control of many small hand muscles and provides sensation to the small and ring fingers. Given its superficial path, it's highly susceptible to irritation, compression, or stretching, especially in throwing athletes.
It sounds like a remarkably intricate system, as you've detailed, designed for robust movement, but perhaps not for the sheer volume and intensity of repetitive extreme stress we see in professional sports. So how do these structures, particularly the UCL and the olecranon, actually cope or perhaps fail to cope with the unique, often pathological biomechanics of overuse? Is it simply a case of too much force, or is there a more specific breakdown in the kinetic chain?
You've articulated the core challenge perfectly. It's rarely just about too much force in isolation, though that's obviously a huge factor. Unlike acute trauma from a single event, many elbow injuries in throwing athletes are indeed overuse injuries. They develop gradually over time because the repeated application of high stresses exceeds the tissue's capacity for repair and adaptation. A fundamental issue is often insufficient rest.
Not enough time to heal between sessions.
Exactly. The body simply doesn't get enough time to recover from the microtrauma, leading to a cumulative breakdown. During the overhand throwing motion, especially in pitching, a staggering amount of force is concentrated right over that inner elbow. Think about the kinematics. Late cocking, early acceleration. That's when the elbow sees its most extreme valgus stresses. And it's not just the peak force, it's the rapid rate of force application. The tissues have to withstand incredible speed.
Okay.
To give you some context, during pitching, the elbow can hit angular velocities of up to 3,000 degrees per second.
3,000 degrees per second, that's extraordinary.
It really is. Simultaneously, those valgus forces can reach as high as 64 newton meters. Think of hanging a 6-kilogram weight from your wrist with your arm out, and compressive forces on the outer side, the lateral radiocapitellar joint, can be around 500 newtons. These are huge numbers for a relatively small joint. Now, that anterior bundle of the UCL, as I mentioned, it's the primary restraint against these valgus forces, particularly between 20 to 120 degrees of flexion, right during that extension phase before ball release. When these forces are repeatedly hammered onto it, especially without adequate recovery, it can lead to microinstability. The ligament basically starts to lose its structural integrity. Fraying or stretching microscopically becomes less effective.
And that instability then causes other problems.
Precisely. It sets off a cascade. You get increased compression on the lateral side, increased distraction medially, and crucially, increased stress and impact on the posteromedial olecranon and its fossa during terminal extension. And that is the direct mechanism for valgus extension overload syndrome. It's really the foundation for understanding the whole spectrum, from tendinitis right through to full ligament tears.
It's clear the elbow is under immense strain, and that kinetic chain breakdown is a key factor. Given these incredible forces, what are some of the most frequently encountered overuse injuries you actually see in this population? And how do you begin to differentiate them, especially when the symptoms might seem quite similar?
That's a crucial question, because yes, the symptoms can definitely overlap, making a precise diagnosis absolutely essential. One very common condition is flexor tendinitis. It's also sometimes called medial epicondylitis, though technically it's often more of a tendinosis, a degenerative process, rather than pure inflammation. It affects the flexor pronator tendons, where they attach on the inner side of the humerus, the medial epicondyle. Athletes typically report pain right on the inside of the elbow, specifically during throwing, particularly during acceleration and follow-through.
Does it hurt at rest too?
In more severe or chronic cases, yes, the pain can progress to being present even at rest. That's usually a significant red flag. Clinically, you'll find tenderness if you press right over the medial epicondyle, and pain often gets worse with resisted wrist flexion and forearm pronation. Then, of course, there's ulnar collateral ligament, UCL injury. We touched on this. This really is the most commonly injured ligament in throwers. The spectrum is broad. It can range from minor damage, just inflammation or a strain, right up to partial tears and, unfortunately, complete ruptures.
And the symptoms for a UCL injury?
Typically, pain on the inside of the elbow, again, particularly during late cocking and acceleration. But very notably, athletes often report a drop in their throwing velocity and control. They might describe a dead arm feeling after throwing. That loss of velocity is often the first thing that alerts them or their coaches that something serious is wrong, because it hits performance directly.
And that's where the famous Tommy John surgery comes in.
Exactly. UCL reconstruction, or Tommy John surgery, involves replacing the torn ligament with a tissue graft, usually from the patient's own body, like the palmaris longus tendon or a hamstring tendon. It's allowed countless athletes to get back to elite competition, but it's vital to stress. It's not a guaranteed fix for everyone, and the rehab is exceptionally long and demanding. Next, we have valgus extension overload syndrome, VES, often dubbed pitcher's elbow, which is a key focus for us today. This happens because during throwing, especially the rapid extension and deceleration phases, the olecranon, that bony point at the back, and the olecranon fossa of the humerus get forcefully twisted and jammed against each other. It's basically an impingement.
Like bone hitting bone.
Essentially, yes.
Mm.
Over time, this repetitive impact wears down the protective articular cartilage on the olecranon. It also leads to the development of abnormal bone overgrowth, bone spurs, or osteophytes, particularly on the posteromedial aspect of the olecranon. This bony impingement is what causes the pain and can limit motion.
You called it pitcher's elbow, but does it only affect pitchers?
Good question. While it is very common in throwing athletes, prevalence is reported as high as 65% in elite symptomatic players. It's definitely not exclusive to them. We also see VOs in other athletes doing repetitive overhead movements with forceful elbow extension. Think swimmers during the pull-through phase, volleyball players spiking, gymnasts tumbling or vaulting, even racket sport athletes serving or hitting overheads, and golfers during their follow-through.
Right, so it's the movement pattern, not just the sport. What are the symptoms like for VOs?
Typically swelling and pain right at the site of maximum bone contact at the back of the elbow, specifically over that posteromedial olecranon. The pain characteristically gets worse with full elbow extension, especially during deceleration or follow-through. A key sign can be a noticeable loss of terminal elbow extension. The athlete just can't fully straighten their arm anymore, often developing what we call a flexion contracture.
So it's not just a pitcher's problem, but really an issue for anyone pushing that elbow to its limits with repetitive extension. What other conditions often crop up in these high-stress environments, maybe alongside VOs or because of it?
Indeed. We also frequently encounter olecranon stress fractures. These are tiny, microscopic cracks in the bone. They happen when the surrounding muscles get fatigued and can't absorb the shock of repetitive impact or eccentric loading effectively. So the stress gets transferred directly to the bone itself. The olecranon, that bony point again, is the most common spot for these in-throwers due to those repetitive compressive forces.
And how does that feel, different from VOs?
The pain is typically an aching pain directly over the surface of the olecranon, sort of on the underside of the elbow. It's usually worse during throwing or other strenuous activity, and in some cases, it can even be present at rest, especially at night. That might indicate a more advanced stress reaction or fracture. Unlike an acute break, these tend to come on more gradually, more insidiously. Finally, ulnar neuritis, often termed cubital tunnel syndrome in a chronic setting, is another significant concern. This arises because the ulnar nerve, as it crosses the elbow, runs through that superficial tunnel behind the medial epicondyle. When the elbow bends, the nerve stretches around the bone. In throwing athletes, this repeated stretching, or sometimes the nerve actually slipping or snapping out of its groove during motion, leads to chronic irritation and inflammation.
So more than just hitting your funny bone.
Much more. It becomes a chronic, painful irritation. Throwers might experience electric shock-like pain starting at the inner elbow and shooting down into the forearm. It's often accompanied by numbness, tingling, or a burning sensation in the small and ring fingers. This typically happens during or immediately after throwing, or after holding the elbow bent for a long time. These symptoms can persist at rest too, especially at night. It's worth noting, while common in throwers, you can see ulnar neuritis in non-throwers too, maybe after prolonged phone use or sleeping with the elbow bent. The key is that chronic irritation mechanism, whether it's compression, stretching, or the nerve actually snapping.
That's a really comprehensive overview of the potential pathologies, but as you mentioned, the range is broad and many symptoms seem to overlap quite a bit. So how do you actually approach the diagnosis to pinpoint the exact issue? How do you make sure you're not mistaking one for another, especially with high-level athletes where getting it right is absolutely critical?
This is precisely where a systematic, really thorough clinical evaluation becomes paramount. It's an art as much as a science, you could say. We always begin with a detailed patient history, and this isn't just about the elbow pain itself. We need to understand the athlete's general health, their dominant arm, exactly how the symptoms started. Was it sudden or gradual? What's the nature of the pain, sharp, aching, tingling, burning? Are there any mechanical symptoms like clicking or locking? And of course, the specifics of their sport, the frequency, intensity, duration of throwing, or other overhead activities. For baseball pitchers, for instance, we know injury rates link closely to things like pitch counts, innings pitched, even how many months a year they pitch.
Right, the workload.
Exactly.
Yep.
Taller, heavier pitchers, those throwing faster, they statistically carry a higher risk. Pitching with arm pain or when fatigued, these are all critical pieces of the puzzle we get from the history. We also ask about any previous injuries or treatments they've had.
Okay, so history first. Then the physical examination must be quite involved too.
Oh, absolutely. Comprehensive physical exam follows. Several key steps here. We meticulously check both active and passive range of motion, flexion, extension, pronation, supination, looking for any deficits. We evaluate muscle strength and the stability of the elbow itself. But critically, we very often extend our evaluation to include the athlete's shoulder, their neck, even the whole kinetic chain down to the legs. Problems upstream or downstream can definitely contribute to elbow issues.
Assessing the whole system, not just the site of pain.
Precisely. We assess muscle bulk and appearance, always comparing the affected elbow to the healthy side to spot any asymmetry or muscle wasting, which might hint at chronic nerve problems or disuse. We also evaluate sensation and individual muscle strength in the forearm and hand, vital for picking up nerve involvement, particularly that ulnar nerve. A crucial part of the physical exam is pinpointing the area of greatest pain through direct palpation, pressing carefully over distinct spots. The medial epicondyle for flexor tendinitis, the UCL insertion point, the posteromedial olecranon for VOS, or the olecranon itself for stress fractures. Then we perform specific provocative tests. These are maneuvers designed to reproduce the symptoms or identify instability. A classic one is the Valgus stress test.
That's the one mimicking the throwing stress.
Yes, exactly. We stabilize the arm and apply a gentle outward bending force, the valgus force, to the elbow, usually bend at about 20-30 degrees to unlock the olecranon. If this causes gapping or reproduces their specific pain, it's positive and strongly suggests UCL instability. For VO specifically, we look for tenderness right over the posteromedial olecranon. We check for that flexion contracture or the inability to fully straighten the arm. We listen for any clicking or grating, crepitus, during terminal extension, which might suggest loose bodies or worn cartilage. And we try to reproduce the pain with forced elbow extension, sometimes called the arm bar test or bounce test, where a sudden gentle overpressure into full extension reproduces that bony impingement pain. These specific tests really help us narrow down the possibilities and distinguish between soft tissue and bony problems.
That detailed clinical assessment sounds incredibly thorough, almost like a forensic investigation of movement, as you say. But I imagine in many cases, imaging is still essential to confirm things, assess the extent of damage, especially when you're considering a high-stakes return to play for an athlete. What imaging do you typically use, and what does it show you that the exam might miss?
Precisely. While the clinical assessment gives us a strong working diagnosis, imaging is often indispensable. For confirmation, for staging the injury, ruling out other issues, we commonly start with plain X-rays, usually AP, lateral, and oblique views. These give clear pictures of dense structures like bone. They're excellent for revealing stress fractures, identifying bone spurs, especially that osteophyte formation on the posteromedial olecranon and VOs, sometimes called kicking lesions when they impinge. They can also show loose bodies in the joint.
Can X-ray show ligament damage?
Not directly, no. They're less useful for soft tissue injuries unless there's maybe calcification. We might sometimes see hypertrophy of the medial epicondyle or thickening of the humerus cortex, suggesting chronic stress adaptation, but not the ligament itself. Now, while less common as the first-line test, computed tomography CT scans can be very useful. They provide exceptionally detailed 3D images of bony structures. They're particularly good at defining the exact size and location of bone spurs or other complex bony issues limiting motion, like osteochondral defects or subtle fractures. If we're considering arthroscopic removal of an osteophyte, a CT scan is great for pre-op planning, mapping the approach to avoid taking too much bone.
Okay, so X-rays for bone basics, CT for detailed bone structure. What about the ligaments and tendons then?
For soft tissues, magnetic resonance imaging, MRI scans, are truly excellent. They give superb visualization of the elbow's soft tissues, critical for distinguishing between ligament and tendon problems that might feel similar on examination. An MRI can also help determine the severity. Is that UCL injury, just a strain, a partial tear, or a complete rupture? That really dictates treatment. Plus, MRI is invaluable for finding stress fractures that might be invisible on X-ray, especially early on when they just show up as bone marrow edema.
Is there anything else you might use with MRI?
Yes, in some instances, we might order an MRI arthrogram. This is where we inject a special contrast dye directly into the elbow joint before the MRI scan. It enhances the clarity significantly, can really help assess subtle ligament tears by showing if the dye leaks out of the joint capsule or fills a tear. So combining these imaging tools with that thorough clinical exam, it gives us a really comprehensive, nuanced picture of the pathology, which is essential for guiding our treatment decisions.
Right, so once you've got that diagnosis nailed down, using all that detailed info from the clinical assessment and the imaging, what are the main treatment routes? Starting, I assume, with more conservative approaches. And crucially, when do you reach the point where you decide surgery is necessary? That must be a huge decision for an athlete.
Absolutely. Once we have a clear diagnosis, our initial approach almost always prioritizes non-surgical management. The very first, most critical step is rest. Or, perhaps more accurately, a period of activity modification. For someone experiencing symptoms for the first time, this might mean 10 to 14 days of relative rest stopping the aggravating activity, followed by a very carefully graduated return to throwing. For those with repeat or more severe symptoms, we often recommend longer, maybe 4 to 6 weeks of active rest.
Active rest meaning?
Meaning engaging in non-painful activities, cross-training, but avoiding the specific movements causing the elbow pain. The aim is to let the inflamed or injured tissues heal, let the acute inflammation settle down, without that constant repetitive stress. Alongside rest, physical therapy plays a pivotal, often primary role. And this isn't just generic exercises. It involves specific, tailored programs designed to restore flexibility, strength, and proprioception, not just in the elbow, but the whole kinetic chain, shoulder, girdle, trunk, lower extremities.
Because it's all connected, as you said.
Exactly. Exercises target rotator cuff strength, scapular stability, core control, hip mobility, all things that indirectly reduce stress on the elbow. A key component of this often involves a mechanics evaluation by a skilled coach or physical therapist. Poor throwing mechanics may be inadequate trunk rotation, delayed arm cocking, not using the lower body properly can place excessive unnatural stress right on the elbow, perpetuating the injury cycle. Correcting these mechanics is vital for long-term recovery and prevention.
Is that easy to do for high-level athletes, changing mechanics?
Honestly, it can be incredibly challenging. For athletes with deeply ingrained habits, making those adjustments can be technically difficult and psychologically demanding. It takes real commitment. For pain and swelling, we use anti-inflammatory medications like NSAIDs, ibuprofen, naproxen. We might prescribe stronger versions if needed. They help reduce inflammation and pain, making it easier for the athlete to engage in their rehab. And in selected cases, we might consider injections. There's growing evidence supporting platelet-rich plasma, PRP injections for partial UCL tears or severe tendinopathies that haven't responded to rest and physio.
How does PRP work?
We take a small amount of the patient's blood, spin it in the centrifuge to concentrate the platelets and growth factors, and then inject this PRP concentrate right into the injured area, usually under ultrasound guidance. The idea is these concentrated growth factors stimulate and accelerate the body's own healing processes. It's not a magic bullet, but it can be a valuable tool in the right circumstances.
So, Professor, when do these conservative measures, as thorough as they sound, give way to considering surgery? It truly sounds like a significant step, especially for an athlete whose livelihood often depends on their physical performance. What are the definitive indicators for surgical intervention?
Indeed, surgery is a significant consideration. It's typically reserved for cases where painful symptoms persist despite a really dedicated, comprehensive course of non-surgical management. Usually we're talking a minimum of 6 to 12 weeks. And crucially, the athlete must wish to continue competing at a high level. For a professional or elite amateur, simply being unable to perform at their usual level because of pain or instability is a very strong driver towards considering surgery. One common surgical procedure for persistent VOs is arthroscopy. This is minimally invasive. We use a tiny camera, the arthroscope, inserted through small keyhole incisions.
To look inside the joint.
Exactly. And through other small portals, we guide miniature surgical instruments to remove those bone spurs on the olecranon, the osteophytes, and any loose bits of bone or cartilage floating around that might be causing pain, clicking, or limiting motion. It's often done with the patient lying face down or on their side, using gravity to help open the joint space. Now, a critical caution here is to avoid over-resection of the osteophyte. Research, including studies on cadavers, suggests removing more than about 9 millimeters of the posteromedial olecranon can actually increase stress on the UCL.
So you could potentially create a new problem.
Precisely. You could cause iatrogenic valgus instability, turning a bony impingement problem into a ligament instability problem. That would be a detrimental complication. So precision is key. For athletes with unstable or completely torn UCLs who haven't responded to conservative care, UCL reconstruction or Tommy John surgery remains the gold standard. As I mentioned, this replaces the torn ligament with a tissue graft, usually an autograft from the patient, like the palmaris longus or a hamstring tendon. This graft is threaded through tunnels drilled in the humerus and ulna, acting as a scaffold for a new ligament to grow onto, restoring stability. There are variations, of course. Sometimes a healthy ligament that's just torn off the bone can be reattached directly. Sometimes a high-strength suture, what's called an internal brace, is used to augment the repair or reconstruction. This might offer increased early strength and potentially a quicker return to play, though the long-term data on that is still evolving.
And what about the ulnar nerve issues? Is there surgery for that too?
Yes. For cases of ulnar neuritis that don't resolve conservatively, or if the nerve is clearly unstable and subluxing, we can perform an ulnar nerve anterior transposition. This involves carefully moving the nerve from its groove behind the medial epicondyle to a position at the front of the elbow. This stops it stretching or snapping painfully when the elbow bends, reducing the chronic irritation. It's a delicate procedure, given how sensitive the nerve is.
These surgical interventions sound quite involved, often reconstructive. What are the typical recovery timelines an athlete and their team can expect? And perhaps more importantly, what are the significant complications they need to be aware of?
Recovery timelines vary considerably, and managing expectations is absolutely crucial. With successful non-surgical treatment rest, physio and athlete might get back to throwing in about 6 to 9 weeks, following a careful phased progression. However, if surgery is required, the recovery is significantly longer and much more demanding. After UCL reconstruction, for example, it can easily take 6 to 9 months, often longer, just to return to competitive throwing, and maybe a full year or more to regain pre-injury velocity and effectiveness. It's a lengthy, arduous rehab process with multiple phases: immobilization, early motion, strengthening, then a gradual throwing program, each with strict criteria to move on.
And for the arthroscopy, is that quicker?
Yes, typically much faster. For arthroscopic procedures like osteophyte removal, the return to throwing is often within 2 to 4 months because there isn't a ligament that needs to heal biologically. As for complications, while relatively uncommon with meticulous technique, they're important to discuss. For arthroscopic osteophyte resection, the main concern, as we said, is iatrogenic valgus instability if too much bone is removed more than that 9mm guideline.
Creating instability.
Yes. Another potential complication with any elbow surgery, especially given the ulnar nerve's path, is iatrogenic ulnar nerve injury. This could cause persistent numbness, tingling, or even weakness in the hand. Meticulous technique, careful nerve identification and protection, minimally invasive approaches, they're all crucial to minimize this risk. And then you have the general surgical risks: infection, stiffness, delayed healing, always a possibility, though thankfully rare.
Right, here's where it gets really interesting, I think. While we often associate these complex elbow injuries mainly with pitchers because of that immense valgus stress, there are compelling instances where a similar pathology crops up in, well, unexpected roles. And these require a truly bespoke approach. Professor, could you perhaps share a particular case that exemplifies this, especially one that maybe challenged conventional rehab strategies and required completely different diagnostic lens?
This brings us to a fascinating case, yes. One that truly underscores the need for a precise, individualized approach, moving beyond just generalized protocols. It really highlights how a seemingly standard diagnosis can have a very non-standard underlying kinematic cause. We do typically discuss valgus extension overload syndrome, predominantly in pitchers, given the mechanics. And there is indeed less documentation on non-surgical management, particularly in athletes whose symptoms are primarily with hitting, not throwing. The case involved a 15-year-old high school baseball catcher. He presented with a chronic 6-month history of right medial elbow pain. Now, crucially, this pain was primarily aggravated by hitting specifically during the acceleration and follow-through of his swing. He did report some mild, non-limiting symptoms with throwing, but hitting was the main problem.
And imaging confirmed VOS.
Yes. An MRI with contrast confirmed the diagnosis. It showed bone marrow edema consistent with the stress reaction in the setting of valgus extension overload on that posteromedial olecranon. But what's particularly important here is his history before he came to see us. He'd already done a 6-week course of physical therapy elsewhere. That program focused on general strengthening forearm pronators, scapular stabilizers, trunk exercises, lower extremity work like squats. A very logical regional interdependence approach, you might think, for a throwing athlete.
Standard stuff. Sounds reasonable.
Exactly. And while his throwing did improve significantly with that initial treatment, unfortunately, his hitting pain didn't resolve at all. In fact, he reported his medial elbow symptoms came right back when he resumed hitting, even after a significant break. This persistent, activity-specific pain, despite standard, regionally focused rehab, immediately flagged to us that while the diagnosis of where the pain was located was correct, the movement diagnosis, the understanding of why he had the pain during hitting, was incomplete. This really set the stage for a completely different diagnostic approach, focused laser-like on his specific movement patterns during hitting.
So the initial, more generalized approach, while logical, just wasn't hitting the mark for his hitting pain. What was different about the movement expert's examination, as you termed it? What did you look for that ultimately led to that breakthrough in understanding his specific issue as a hitter?
This is where the paradigm shifted, moving beyond just tissue pathology to look at the kinesiopathology, the faulty movement. The key was moving beyond standard strength and range of motion tests to a truly systematic observational movement examination. During the initial static observation, one significant finding was an excessive resting right humeral external rotation compared to his left arm, even though he actually had greater right scapular internal rotation. This subtle postural discrepancy already hinted at a potential underlying kinematic issue.
A subtle misalignment at rest.
Exactly. Then, when we simulated his hitting motion during the exam, and this is where it gets highly specific, we observed a marked right humeral external rotation during the drive phase of his swing. We noticed his humeral alignment seemed to compensate for the expected forearm supination of the trailing arm, making the epicondyles appear almost parallel to the line of force at impact, a subtle but critical observation. The crucial diagnostic moment, the real aha, came when we applied a sudden valgus force to his elbow in that simulated hitting position. It immediately reproduced his symptoms. But here's the breakthrough. When we manually internally rotated his humor slightly before reapplying that same valgus stress, the motion became completely pain-free.
Wow.
That single observation was pivotal. It identified excessive humeral external rotation as his primary movement dysfunction, causing the elbow stress during hitting. It wasn't a general weakness or instability, it was this specific rotational compensation.
So what was causing that excessive external rotation?
Good question. We then systematically identified several contributing impairments. Firstly, he had a significant loss of bilateral shoulder internal rotation, much worse on the right, only 10 degrees compared to 30 on the left, measured at 90 degrees abduction. His total arc of motion on that side was only 125 degrees, well below the expected 160 or so. That indicated significant posterior shoulder stiffness, tightness in the posterior capsule. Secondly, we found weakness in key humeral internal rotators, specifically the subscapularis and pectoralis major. They were a full grade weaker on his right side. Thirdly, a subtle but measurable limitation in pronation on his right, 60 degrees versus 80 on the left. And finally, there was notable weakness in his right gluteus maximus, evident during muscle testing and watching him do a single leg squat. This suggested decreased pelvic and trunk rotation power, which is absolutely crucial for efficient hitting mechanics. If you don't generate force proximally, the body compensates distally, often leading to excessive stress further down the chain, like at the elbow.
That's an astonishing level of detail, connecting glute weakness to elbow pain during hitting. It really highlights how these minute kinematic details, seemingly unrelated to the elbow itself, can have such a profound impact. So, Professor, how did these precise findings then translate into his actual rehab? What were the tailored interventions, and what was the biomechanical thinking behind each choice, especially moving away from that previous, more generalized approach?
The treatment plan became singularly focused on preventing that excessive humeral external rotation during hitting. It was a direct shift away from the general exercises. We moved from just strengthening muscles in isolation to correcting and re-educating the specific movement patterns relevant to his batting swing. The goal was activity performance changes, not just isolated muscle gains on a chart. We started by improving posterior shoulder flexibility because that tightness was clearly driving the compensatory external rotation. We used soft tissue mobilization on his posterior shoulder muscles, and that immediately improved his internal rotation by 30 degrees after just one session, confirming our hypothesis.
Instant feedback.
Pretty much. We then taught him self-mobilization techniques using a foam roller or lacrosse ball to maintain those gains. We also prescribed eccentric supine shoulder internal rotation exercises with a light dumbbell. Eccentric loading is known to increase sarcomere lengthened muscles and decrease tissue stiffness, directly targeting the physical properties of that stiff posterior shoulder. Concurrently, we focused on increasing humeral internal rotator strength and stiffness to provide dynamic control over that rotation. Prone and supine internal rotation exercises at 90 degrees abduction specifically targeted the subscapularis. We also strengthened his pectoralis major and forearm pronators using a heavy resistance band during horizontal adduction and pronation exercises. Crucially, we cued him to avoid letting his shoulder blade rotate inwards during this, which helps stretch the posterior shoulder while strengthening the internal rotators in a functional way. This also dynamically supported the UCL.
So strengthening and stretching simultaneously in a way.
In a functional context, yes. Then we incorporated neuromuscular re-education specifically for the hitting motion. This involved a really interesting drill, using a light bar, simulating a bat. We taught him how to achieve the necessary forearm supination for the swing without compensating with that excessive humeral external rotation. He actually watched his own cubital fossa, the crease of his elbow, to monitor the alignment. The goal was precise control of the humerus while activating the flexor pronators at the right time to provide dynamic stability against valgus stress.
Teaching the body a new pattern.
Exactly. And we absolutely addressed the proximal contributions to the lower body and trunk. We integrated gluteal muscle training in a transverse rotational pattern using heavy resistance bands and specific drills. The aim was to improve his pelvic and trunk rotation during batting. Better rotation proximally reduces the need for excessive compensatory movement at the shoulder and elbow. It allows force to be generated more efficiently through the kinetic chain. We even modified his daily activities, like his bench press technique, to promote scapular adduction and posterior shoulder stretch under load, ensuring his gym work supported his rehab goals. Pallof presses were added for trunk stability and rotation.
That's an incredibly detailed rehab plan, truly bespoke. It really shows the depth of that movement-focused approach. How did you then get him back to actually hitting, and what specific drills did you use to reinforce these new, better movement patterns during the actual batting swing itself? That's where the rubber meets the road for a baseball player, isn't it?
You're absolutely right. The return to sport phase is critical testing and consolidating those new movement patterns under increasing load. It was meticulously graduated. We used a phased interval return to hitting. Started hitting off a P, then progressed to soft toss from a coach, and finally to hitting against a live arm in a batting cage.
Taking it step by step.
Very cautiously. Progression was strictly dependent on him being completely pain-free at each stage, with adequate rest days built in. This ensured the new patterns were consolidated without overloading the elbow and causing a flare-up. Now, to specifically address that trailing elbow position, preventing it from moving anterior to the bat knob, which increases valgus stress, and to ensure the humerus stayed in relative internal rotation during acceleration and follow-through, we used two highly specific hitting drills. The first involved using a 10-pound dumbbell. He moved it through the first half of the swing, then held an isometric contraction at the typical contact point. This forced him to control the weight while maintaining proper humeral rotation. The second drill used a lightweight PVC pipe, doing the same thing, holding isometrically at contact before completing the swing. The light pipe allowed for rapid movement, reinforcing the muscle memory for the correct pattern.
And how did you ensure he was actually doing it correctly?
Immediate biofeedback was key here. We used his own phone to record short videos of his swing from various angles. We'd review them together instantly, pointing out the subtle changes in his cubital fossa alignment, reinforcing that desired humeral internal rotation even as his forearm supinated. This visual feedback was incredibly powerful for self-correction and motor learning. He could see the difference himself.
The precision of that intervention is truly remarkable. It highlights a depth of understanding miles beyond just general strength training. So what were the outcomes? And connecting this back to the bigger picture, what does this case really exemplify about the unique role of physical therapists and perhaps clinicians more broadly as movement experts?
The outcomes were, frankly, impressive, and a strong validation of this detailed, movement-focused approach. After just 4 physical therapy sessions, the young man was able to return to all throwing activities without any recurrence of symptoms. His shoulder internal rotation range improved significantly from that limited 10 degrees up to 30 degrees, showing we'd addressed the posterior stiffness. Even more remarkably, after only 9 sessions over about 5 weeks, he reported 100% symptom alleviation with hitting. At his 7-month follow-up via phone, he confirmed he was back playing baseball fully, as a catcher, with no recurrence of elbow pain.
That's fantastic. A complete resolution in just 5 weeks.
It was a great result. And connecting it to the bigger picture, yes, this case truly exemplifies the unique and critical role of physical therapists, and indeed any clinician thinking beyond just the site of pain as movement experts. It profoundly challenges the assumption that a general regional interdependence approach focusing broadly on scapular or rotator cuff strength is universally effective. While that concept is valid and often a good starting point, applying it generically, as happened in his initial therapy, clearly wasn't sufficient here for his specific hitting-related VOs.
It needed that extra layer of specificity.
Exactly. This case underscores the critical importance of a systematic, granular, movement-focused examination. That process allowed us to establish a precise underlying movement diagnosis, in his case, excessive humeral external rotation causing valgus stress during hitting. This precise diagnosis then dictated a truly tailored and efficient treatment plan. It highlights that when initial, more generalized interventions fall short, a deeper dive into the specific kinematic dysfunctions is often the key. It moves us beyond a one-size-fits-all approach to truly bespoke patient care, especially for high-level athletes, where tiny kinematic details matter hugely, not just for performance, but for career longevity and injury prevention. It forces us to ask specifically what's happening during the painful movement, not just where the pain is located.
This case is just a brilliant example of that personalized care moving beyond general principles to truly specific interventions. It really does reshape one's perspective. Looking forward, then, Professor, what are the key takeaways for prevention based on this type of deep understanding? And what areas do you think still need more investigation, more research in this field to advance our knowledge even further?
For prevention, the key takeaways remain quite foundational, but they're profoundly reinforced by this detailed understanding of kinesiopathology. Firstly, proper conditioning is paramount. Ensuring the athlete's body, the entire kinetic chain from legs to shoulder, is robust enough to handle these immense stresses. That includes strength, power, endurance, and flexibility across all relevant areas. Secondly, meticulous technique is absolutely crucial. As we saw in the case study, even subtle flaws in movement patterns like that compensatory humeral rotation can dramatically increase stress on vulnerable joints. This often needs ongoing coaching, regular biomechanical checks, maybe using biofeedback tools to spot and correct deviations before they cause pain. And thirdly, critically, sufficient recovery time must be prioritized. Overuse injuries happen when the body doesn't get enough time to heal and adapt between high-intensity sessions. For younger athletes, specific guidelines, pitch counts, mandated rest days, avoiding playing on multiple teams simultaneously, these are vital safeguards. They must be strictly adhered to, allowing for proper biological adaptation and preventing chronic injury. Understanding tissue fatigue and repair is key. So conditioning, technique, and rest the fundamentals, but viewed through that sharper biomechanical lens. What about future research? Where do we still need more information? There are definitely unanswered questions. While we have considerable biomechanical data for pitching, there's an ongoing need for much more detailed data on elbow forces, specifically during hitting. It's a less studied area. Understanding the precise nuances of how forces generate and transfer through the kinetic chain and the batting swing could unlock entirely new preventative and rehab strategies. For instance, what's the exact role of the wrists and hands? How does bat speed correlate with elbow loading? Furthermore, we need to quantify the precise contributions of the lower extremities, trunk, scapula, and humerus, to elbow sources during hitting. This would help build a more complete, evidence-based model of the kinetic chain in batting, identifying specific, measurable targets for intervention. And finally, there's a significant need for more accessible and reliable examination strategies to assess that intricate link between shoulder movement and elbow pathology. The case study highlighted a manual diagnosis of humeral rotation, which requires a highly skilled clinician. Developing more objective, widely applicable tools and standardized protocols would be a huge benefit, helping clinicians identify these precise movement dysfunctions earlier and more effectively, perhaps democratizing this level of assessment. This raises an important question. Professor, what truly stands out to you about applying this highly individualized, movement-focused approach to patient care? Not just in this specific case, but as a broader principle for our medical professional listeners. What truly stands out, beyond the impressive outcome here, is the profound confirmation that a targeted, movement-based diagnosis can be far more effective and, frankly, more efficient than a generalized approach, particularly when that generalized approach has already failed. It forces us as medical professionals to really scrutinize the specific kinesiopathology, the abnormal movement causing the pain, rather than just treating symptoms or applying a broad best practice program that might miss the mark. It highlights that even in common conditions like VOs, the underlying biomechanical driver can be highly individual. One size rarely fits all. It reminds us that every patient is unique, and sometimes the solution lies in those minute, precise details of their movement patterns, not just the obvious anatomical location of their pain. It's about being a true movement detective, really digging into the why. Hashtag tag outro. What an insightful deep dive today. We've really unraveled some of the complexities of elbow injuries in athletes, particularly that valgus extension overload syndrome. We've journeyed from the intricate anatomy through the common overuse injuries and explored the precision needed in both diagnosis and treatment. Indeed. And perhaps most importantly, we've seen how a really detailed, movement-focused assessment can dramatically shift patient outcomes, especially when those conventional approaches maybe don't fully address the underlying kinematic dysfunctions. That case of the high school catcher illustrated it perfectly, didn't it? It really did. If you found this deep dive valuable today, we'd greatly appreciate it if you could rate and share this deep dive with your colleagues. Your feedback helps us reach more medical professionals like yourself. And a final thought to leave you with. As medical professionals, how might this emphasis on minute kinematic details and their potentially widespread impact reshape your own diagnostic lens for complex musculoskeletal pain? How might it encourage you to move beyond generalized protocols towards truly bespoke patient care?